We have a panel starting, and cervical cancer vaccination. We've been hearing about it a lot these days. A very an informative conversation around this is very important, and that's what today's panel discussion will be all about. Where the panelists will be sharing valuable insights in the role that vaccination can play in preventing cervical cancer, and various insights around this topic itself. So let me introduce you to our panelist. Um, we have Dr. Amitav Banerjee. He's a distinguished epidemiologist and professor at Dr. D.Y. Patil Medical College, Pune. With over 45 years of experience in public health and epidemiology, Dr. Banerjee has been at the forefront of research and has received global recognition for his contribution to this field. Thank you, Dr. Banerjee, for being with us today. It's an honor to have you at the IFM conference.
Thank you, Dr. Rui. It's a pleasure and a privilege. Thank you.
Thank you so much. I'll introduce our next panelist, Dr. Sonal Batla. She's an expert in obstetrics and gynecology and the head of the department at Sant Paramanand Hospital, Delhi. With years of clinical expertise and passion for philanthropic work, Dr. Batla has contributed immensely to women's health, particularly in rural areas. She brings a wealth of knowledge on the practical impact of cervical cancer prevention through vaccination. A very warm welcome, Dr. Batla.
Thank you, Dr. Huda.
And our next panelist is Dr. Sujata Mittal. She's a senior gynecologic oncologist and preventive oncologist with over 35 years of experience. Trained at premier institutions, Dr. Mittal is also a holistic cancer coach and functional medicine expert. She is here to share her expertise on integrative preventive oncology into cancer care, especially through vaccination. A very warm welcome, Dr. Mittal. I hand over to Dr. Huda now. She will be moderating this panel. Over to you, Dr. Huda.
Thank you, Dr. Rui. Welcome, panelists. And
Thank you. Thank you.
in front of you all, I feel so small. Very big achievers we have on panel today. And I would request Dr. Amitav to share his presentation, and then we will start with the questions. And
Thank you, Dr. Hudda. Thank you. I am actually an epidemiologist, so I just deal with numbers at the population level. So, and a clinician sees the cancer patients. So that perspective is different. And when we see the population level, we have to weigh the risk benefit, we have to weigh the burden. And I will just present some figures, what happened at the population level over the past 3 decades, how the cervical cancer trend came down. Actually, what we are hearing is that cervical cancer, India has the largest and all that. India will have the largest because we have a large population. But if you see the relative past 3 decades, the precipitous fall in cervical cancer incidence, and I will just share some figures which should help making the policy decision. At public health decisions are different, clinical decisions are different. So I will just share the slide. I think I have a option of sharing the screen.
Yes.
Is it visible? Okay.
Yeah, it is there.
Let me get the Can you? This is this would be the strong. What are the risk factors and incidents and trends? We know the risk factors well, and what is the role of HPV, and what are the precancerous lesions and their course? Because up till now, all the trials have been only measuring the surrogate outcomes. There have not been trials long enough to measure the actual outcome, that is cervical cancer. So for that, we should know the natural history of the intermediate lesions, that is CIN1, CIN2. Then evidence of HPV vaccines. What is the present evidence? The evidence, what are the gaps in evidence? And because when we are thinking of rolling it out on a large scale level in the universal immunization program, we should be very sure of the evidence, because if we give the immunization mass rollout, we won't have a control group to actually weigh the evidence later also. So we should have a cohort first. We should have a good data, good evidence before taking a big decision. Like, and what are the competing mother and child health problems? And what should be
Dr.
the recommendation?
Banerjee, your slides are not moving. Could you please put it
Yeah.
on slideshow or maybe reshare the
Is it
screen?
is it moving now? I have changed the slide.
No, it isn't. Could you please reshare the screen? Now it is changing, though it is not on slideshow mode, but the slides are changing now.
Yeah, is okay now?
We are on risk factors for cervical cancer right now. That's the slide, the third one. That's what we can see.
Yeah. Now is it okay now? I have
Yes.
changed it. So these are the basic figures we should important for policymakers. That what is the incidence? New cases is 14 per lakh, and the deaths is 9 per lakh as on today in India. 9 per lakh women, and decline is more than 21%, and decline on incidence is 21%, and decline in mortality is 32% in 3 decades. That is from 1990 to 2019. So this is important to know. The incidence is as on today is 14.7 per lakh women, and death is 9 per lakh women, 9.2. And there has been a decline in incidence from 21% and decline in mortality 32% in the last 3 decades. This is before the rollout of the HPV vaccine. So we are already seeing a sharp decline. This may be due to the overall control of the risk factors like multiple sex partners, genital hygiene, less number of children, safe sex because of the HIV and other things. People are becoming more aware. So this is the reference I have given. This is an article in BMC Cancer. So I have given the reference. And just to compare, like we are worried about a woman in India, the maternal mortality rate is 97 per 1 lakh childbirths. That is almost 10 times than the deaths from cervical cancer. 10 times mothers die, they do not reach the age of having cervical cancer. So if you see in public health, we have a competing priorities. We are neglecting our mother health. Antenatal care is not there. Natal care is not there. Remote areas, gynecologists are not there. They are not giving the maternal care as well as screening for cervical cancer. Because even after if you roll out the HPV vaccine, you will still require the screening for cervical cancer. For that, you require gynecologists, pathologists at the remote areas. So we have got 10 times higher priority for preventing the maternal deaths then rolling out a vaccine which will work after 20 years, which is not when there are a lot of gaps in evidence. Is the slide changed?
Yeah, it is changing.
So these are some of the gaps. What is the risk factor of human papilloma virus? A risk factor. There are more than 150 strains, almost 200 strains of HPV. As on now, we know it is 16 and 18, which are the high risk, and the vaccine includes this. So majority of HPV infections are asymptomatic and resolve spontaneously. So prevalence of HPV varies from 2 to 42%. This is also important because the high risk of HPV, as brought out by earlier speakers, is the multiple sex partner sexual experimentation. That's why they recommended 9 to 13 years of age. That is for the Western cultures. And most of our Indian culture, I don't know. We should do studies ki how many are having multiple sex partners from their teenage years. Many of our women may not have a first sexual encounter at the 25 years of age, and then they say HPV vaccine doesn't work after 25 years. So these are some of the issues. Then the higher prevalence of 42% is the commercial sex workers, people with AIDS and HIV. So if we want to test the vaccine fast, we should test it out in the high risk group first rather than going for the general population. I am nothing against the vaccine, but we have to be very sure whether the attributable risk reduction is there or not. In particularly people with low risk Indian culture. So we can try it out among commercial sex workers or people with HIV AIDS before rolling out. Then high prevalence found in patients with cancer, women living with AIDS. But again, there is a paradox because the commercial sex workers may again be in the age bracket 25, 30 years. But again, we don't know whether giving it 9 to 13 years will prevent in the long run. So these are some of the issues. So these are some of the natural history of This early lesions, precancerous lesions are cervical, intraepithelial, neoplasia 1 and neoplasia 2, CIN1 and CIN2. Majority revert back. After some time, they revert back to, they clear by themselves and they do not progress to. So we, and most of the trials, they have measured this CIN1 and CIN2 as clearance, which is again gap in the strong evidence, because they would have cleared by themselves even without the HPV vaccine. And there are hardly any studies to test the final outcome. We are using the intermediate outcomes. So this is one gap. So because of that, this is the limitations in evidence. We do not know how well HPV vaccination will protect against cervical cancer. Trials have not focused on the outcome, final outcome. They have too few participants and did not follow them for long enough. Cervical cancer may take decades to develop. And you see, most of the people will go who may not be at high risk. They are well educated, they are having safe sex, they are not having multiple partners. And another thing I am worried is the HPV vaccine is promoted with so much of propaganda that people will not go for cervical cancer screening. Even the vaccine manufacturers say even after you have the vaccine, you cannot do away with cervical cancer screening. And there have been some studies which say that if the cervical cancer screening is in place, the extra protection is not given by the HPV vaccine, because we still don't know whether there will maybe strain replacement. And I was reading just last week a very interesting news article in Chennai. I think in Chennai, many screening centers for cervical screening refuse cervical cancer screening to single mothers, or not single mothers, single women. They refuse cervical cancer screening to single women, saying that it is only for married women. So this is very strange. A single woman is not having access to cervical cancer screening in many centers in Madras, whereas the vaccine is being promoted up to 9 to 13 years in teenage girls. So there is some contradiction here. Because what I am saying is the public perception would be that this is a magic bullet. That now I have gotten the HPV vaccine, I can indulge in any type of behavior. I do not have to go for cervical screening. So these are the cultural, social factors which I have to keep in mind, which can be the side effect of high pressure promotion of the vaccine, which we don't know the long-term efficacy. I am not talking of side effects at all, but even for efficacy, even for the budget, we have to be very certain, because once you roll it out on a mass level, you cannot take it back. And as it is, we have seen for the past 3 decades, the incidence is falling, the deaths are falling from cervical cancer, and everything would be attributed to vaccine, but it has already come down. If you see then published numbers of randomized trials may overstate the efficacy. As I said, testing occurred too frequently in the trials and then in real world settings, which may show that most of the lesions are regressing, which they regress in any case. CIN1 and CIN2. Trials use composite surrogate outcomes, some of which, such as HPV infection, and even HPV infection cannot be a long-term predictor of cervical cancer until we have completed the trials. Subgroups were overanalyzed. So there were a lot of, there is a paper, I will be citing the paper. If you read that paper, it is in the Journal of Royal Society of Medicine, that brings out the gaps in the literature. The trial population have limited relevance and validity for real world setting, because most of the trials were done in women. No trials have been done in teenage, 9 to 13 years. They tried it about 10 years back in Gujarat and Andhra Pradesh. There were certain adverse events, there were death of certain tribal children. So after that, no trial in teenage has been done, and we are trying to roll it out on a mass scale among teenagers. We don't know who will monitor the adverse effects. I mean, we have to see in public health, we have to see the logistics. Trial women are older, and the target population we are aiming is a younger girls. We do not have enough data on the benefits of women who may not have been exposed to HPV before they were. So there are a lot of question marks. There are a lot of gaps. Surrogate outcomes I have already discussed will not eliminate screening. This is important, because when you are planning a policy, how it will change the practice, it is not going to change the public health practice, and it is not going to give any extra advantage in prevention of mortality from cervical cancer if you have a good screening program in place. And as I said, last 3 decades, the cancer deaths have come down drastically. Long-term efficacy and side effects are not known. There are some evidence in girls of before sexual activity, but they are not very large sample size. Ongoing observational studies may tell us about the long-term effects on rates of survival, but it will take many years before we have evidence. That's why we do not roll it out at a mass level. We can give it in the market, whoever wants to take it. And as I said, if you want to launch trials, it can be done in the high-risk groups, high-risk societies, and then followed up rather than in the general population because we will lose the control group. Then, as I said, there have been some past mishaps. HPV vaccine trials among adolescent tribal girls undertaken in low-key manner in India, 2009. Gates Foundation conducted trials. There was an unethical violation. It was described as an observational study, whereas it was an intervention studies, and there was death, and it was investigated the deaths there. There was a public outcry that was investigated by a parliamentary committee, and the committee indicted the Gates Foundation and ICMR for irregularities in unethical trials and recommended a detailed investigation. More than 10 years, no investigation has been done. So these things should be cleared before rolling out on a still larger scale, because as it is, we do not have the adverse events reporting system in our country. We do not have the health services in the remote areas which will report the adverse event monitoring and all. This should be put in place before we are thinking of a large scale. My idea is whether to put it in the national program. As on today, it would be too premature. So this is the way forward. Should first monitor further, as it is the incidence has fallen down last 3 decades. So we should monitor further whether the other measures are bringing down the safe sex and protection and other genital hygiene. And HPV subtype prevalence, we should require more studies because we may find that other strains are coming up due to vaccine pressure. 1618 is now, you have a vaccine for 1618. After some years, it may be the other strains which may come up. So we have to do that research first. Ensure cancer surveillance and registration are in place before mass rollout. National long-term efficacy and effectiveness studies should be there, and most important, adverse events reporting system should be in place. So these are some of the references. This is the first one is very important, which gives in very clear terms what are the gaps in evidence, with being totally neutral. What are the gaps in evidence? And this is one which I had just written an article for the general public, which has got all the links to number of references regarding the different gaps in literature regarding the adverse events. So that not to clutter the PowerPoint, I have just given one reference and other links are there in that. So I think that's all. Thank you.
Thank you. Thank you so much, Dr. Amitabh. A couple of questions that I wanted to ask you. If the immune system is compromised, would the vaccine still work?
Immune system.
Yeah, if it's a compromised immune system, should we go ahead and give the vaccine?
We don't know, madam. I mean, even if the immune system is not compromised, as I said, we are making the measurements in the interim outcome measures, like the interim lesions. I mean, we are not having and you are very right that we don't know. Like I suggested, we can try the vaccine in the HIV patients, but again, that's the important point there. If they have got an immune deficiency, whether vaccine will go, and we may get spurious results once again. So that's a good question. I think that's yeah. So there are many gaps.
So basically, does it help us to trigger immune response, make antibodies? What?
Yeah, it is. That is the measure they have done. That's why it says they have measured the antibodies and they have measured the initial lesions.
I'll come to you, Dr. Sujata. Does the vaccination, so I think that's answered. I wanted to ask you the healthy immune system, I wanted to ask that question. We'll ask this to Dr. Sujata. I know you are very eager to speak on this. And of course, we come to your presentation now, Dr. Sujata. And I would request panelists to give smaller presentation. So because of the lack of time, we may not be able to discuss all questions. Thank you.
So first of all, thank you to IAFM for giving me the opportunity to talk on this subject, which is very, very dear to me. And because I've been talking about the data and the science, which I want my fellow beings to know, to understand. And I've been removed from multiple of the groups. And I've been criticized for the same, that the PM is fighting for the cervical cancer. And I'm really, really thankful to Dr. Amitabh Banerjee for putting up the data regarding the lower incidence of the cervical cancer and the need for the screening, which will never go in spite of giving the vaccine. So again, thank you for IAFM for giving me the opportunity to present certain things which I really, really desire that my fellow doctors understand. And I would really quicken up because, but still there are a lot of things. So I'll be sharing my screen. Please do let me know whether.
We can see your screen, but not the presentation yet.
Just a second. Just a second.
Yes.
Is it visible?
Yeah, it's
Yes.
visible. If you can put on slideshow,
Yeah,
please.
I'll do that. Okay.
Yeah.
And yeah. So I'll say that it is a forced mandate by the pharma. It is not needed. Unlike Dr. Banerjee, Dr. Amitabh, I'll say this vaccine is not needed. First few slides, I would like to highlight what they are trying through. They are playing, the companies, the media, and certain institutes are trying to play with the words. For example, here I put up NCI, National Cancer Institute, USA. This is for the public. So what they are saying, HPV can infect anyone regardless of their sex, gender identity, and sexual orientation. Most of the HPV infection don't cause cancer. High-risk HPV infection that persists can cause cancer. They can. It is not 100% sure that HPV will cause the cervical cancer. Now, the latest books I have read, because I am conducting colposcopy training program, they are saying HPV alone persistence of the HPV infection alone cannot cause the cervical cancer. There have to be certain factors. For example, the most important being the decreased immunity. If the body's immunity is lowered, it can cause a cervical cancer. And in the last line, they're writing, HPV vaccination can prevent cancer. So this word can, if we are giving an antibiotic, we don't write that ampicillin will prevent this particular staphylococcal infection. It is always written ampicillin is effective against staphylococcal infection. So these are the type of the English language is being used to fool us. Then another important study, which was in the Lancet in 2007, we can understand very clearly. It says, that invasive cancer arises over many years, even decades, and only the minority of the women with pre-cancer with a peak or plateau in the risk when the risk at about 35 to 55 years of the age. So it takes decades to develop the cervical cancer, which Dr. Amitabh, Dr. Anjali has also told us. Now, this is the study by the IARC 2017. So suppose 300 million women are infected with the HPV infection, only 0.5 will develop the cervical cancer. So this is the study. So is it really needed to vaccinate all the women? And this is not the actual number of the women or the girls. This is the number who are infected with the HPV infection. And out of this, only 0.5 million will develop the cancer. And HPV vaccine doesn't cover all the strains of the high risk or the oncogenic HPV infection. The progression to, again, the same IRC, which has done a lot of studies on the vaccine, even in India, and it has been funded by the Bill Gates, and they have done the studies in India, AIMS also. They are writing the progression to pre-cancer and cancer is slow and is a very uncommon outcome for the screen positive women. So if we are writing and saying it is a very uncommon outcome for the positive women, then why the vaccine is being made when the outcome is very, very less when the chances of getting the cervical cancer is very less. Then again, up to 80% of the women will harbor oncogenic HPV during their reproductive life, but only 1 in 10,000 or fewer will develop cervical cancer. This is written by the IARC 2017 key points. They're writing 1 out of 10,000 will develop the cervical cancer if the HPV infection persists. Then, is there again the need for giving the vaccine? The latest book written by Desire, who is a world-known entity, as already told by Dr. Amitabh, that the lowered immunity by through oral contraceptive, multiple sexual partners, tobacco smoking, all these are responsible. Plus, as Dr. Anjali Huda told us, that a deficiency in nutrients such as folate have been linked to the cervical oncogenesis, and smoking, the infection of the tobacco carcinogens with carcinogenic HPV increases the risk substantially because it reduces the immune mediated HPV clearance. So these are the most important things. If we can highlight and the media can talk about HPV vaccine, why OCs are being distributed freely in the government hospitals to our young girls, because once the OC increases, the chances of having the cervical cancer tremendously, because it doesn't it because of the OC, because OC is lower the immunity, they body is not able to clear the HPV infection, and once the HPV infection is not cleared, then the chances of having the cervical cancer increases tremendously. All these points, all these things need to be highlighted by the media properly. A country where the sexual promiscuity was not present at all. It was there, but very, very minimum. Now our girls by the age of 24 to 26 are by the age of 12, they are sexually promiscuous, just like Western countries. They are using pills which are freely available in the government hospitals, and they are having the multiple sexual partner. A girl by the age of 26 is coming to us having 2 or 3 minimum partners. So why we need to emphasize, we need to publicly tell them these are the risk factor, or these are the things causing the cervical cancer, and vaccine is not going to prevent all the cervical cancer cases. So this is, again, I'll just hurriedly, because it has been already told about. So what are the limitations of the vaccines? Limitations of the vaccines which are not known to everyone. Vaccines are see why the vaccines are given, so as to prevent the diseases. Vaccines are given to the healthy people for the prevention of diseases that they may never get in their lifetime. So they should have a very excellent and high safety standards. But HPV vaccine do not replace currently available methods to screen or treat the cervical cancer. And we need to understand that the death rate of the cervical cancer in the girls between 19 to 20 is almost zero. And we are giving them lot of illnesses by giving this vaccine, which I'm going to show you just now, at least 55 studies and number of the cases which trials are going in the America court. I'm going to tell you the numbers. So the what studies have shown by the Garadas and Novik in 2010 and 2012 and 13, that the short-term risk from the vaccines to otherwise healthy individuals seems to significantly outweigh the yet unproven long-term benefits. Because girls are not going to get the cervical cancer, especially in our country, cervical cancer before the age of 35, or rather, I will say before the age of 40 is very, very uncommon. And by injecting HPV vaccine and the trials, the future 2 trials, Patriotica trials, all these have proved that the antibodies will be remaining in the body for maximum 9 years. So suppose you vaccinate a girl of 15 years, and suppose you take that the antibodies will persist up till 10 years. So by the age of 20, the body antibodies will persist till the age of 25 years. And as per the screening protocols, we are not supposed to start the screening before the age of 26. And also, books also write, the studies also tell us that by the age of 26, the body has got so much of the capacity to remove the infection that hardly 1% of the chances are there that the persistent HPV infection will harbor. So again, why to give when already the studies are showing that by 2 or 3 doses, the antibodies will persist from maximum to maximum by 9 years. No HPV, again, the same thing. It is not covering all the carcinogenic types. So the women vaccinated before first intercourse remain at risk for infection and cancer due to other non-vaccine types. The human clinical trial data for 2 HPV vaccines in the market, they have got very, very troubled safety profile, and which requires accurate re-evaluation with the risk and benefit ratio. And it should be urgently, yes, Dr. Amitav told that there are already recommendation that the safety profiles of these 2 HPV vaccines should be studied, and whether really it is necessity to give them, it should be reassessed and guidelines should be changed accordingly. This is a study. I hope everyone is able to see this study. This is and by this quoting this slide, I just want to tell you that how they play with the numbers in the mind of the doctors also, because we read just to understand what the literature is saying, and how they play with in the writing the reviews, in writing the papers, in the writing the research, they play with the minds of the people. Authors says that HPV persistent infection initiate 5% of all the human cancer, including cervical and oropharyngeal cancer. HPV vaccine prevent HPV infection but do not eliminate existing HPV infection. So here they are writing that 5% of all the human cancers are caused by the persistent HPV infection. And now see what they are writing. Cancer arising from the persistent HPV infection, although occurring only in minority of the HPV positive individual, only minority of the HPV positive individuals, this account for 4.6% of the 14 million new cancer cases. See, here, I think from my side, I understand that they should be writing that a persistent HPV infection is responsible for 4.6% of all the cancers. But here they are playing with the words in the terms 14 million new cancers, and out of which 4.6 is because of the persistent HPV infection. And here again, see the play of the words. HPV associated cancers comprise 29.1% of all 2.2 million infection related cancer. So this is the type of the research which play with the words, play with the figures, and as Dr. Amitav told us, they say that this is the troubling, means cervical cancer is a major disease. It is second most common disease in the common cancer in India. So the vaccine is required. In fact, and this is the 55 studies where they have highlighted the type of the problems, the children, those who have suffered. And as you will see, you can have all this from me, that anaphylaxis, SLE, disseminated encephalomyelitis, then pediatric multiple sclerosis, CNS demyelination, autoimmune disorders, POTS, posterior hypotension. So these 55 to 60 studies are there. And I will tell you that only in the HPV vaccine case, I have found that two studies have been retracted. And because they were very, very indicting and telling us, one of the studies was, yes, a lower probability of pregnancy in females in USA aged 25 to 29 who received HPV vaccine injection. This study was retracted and no reason was given to the scientist, to the author. Another study was retracted from the Indian Journal of Pediatrics or Medical Ethics, where it has shown that the increased incidence of the cervical cancer in Sweden after HPV vaccine, because initially author changed his name. He under the disguise of some other name, he published the data, and then he had to retract the article retracted and said that why he used another's name or some other name instead of writing directly to the journal editors, and because of the pharma company pressure. And it is really evident that it was all because of the pharma pressure that all this was done. So ASIA, that is autoimmune inflammatory syndrome induced by the adjuvants. This is a new term, and this has been highlighted repeatedly in the HPV injection. This is, I want to tell my all fellow doctors that they should understand that the death because of the cervical cancer in the age between 9 to 20 or 25 is not there, but we are giving so much of the problems to the girls. And we are here because in India, we don't know, we don't have any system. As Dr. Amitabh told you, we don't have any particular, there is a system, but it is not working. We have seen with the COVID patient, the children, those who have died, their parents are struggling to report the deaths, and they're struggling with the Supreme Court right now. So to put the adverse events registry is not proper, and people are not aware. 7 deaths in the past trial that occurred, and they are labeled as mysterious. So as a doctor, we should understand, first of all, what we are giving and why we are giving and what is the impact is there. So this is data from America, which says that the Med Alert search, it has been picked up by the Med Alert search engine. As of November 2024, the federal vaccine adverse events reporting system has contained 78,168 reports of HPV vaccine reactions, hospitalization, injuries, and deaths. And this includes 641 related deaths, 7,924 hospitalizations, and 818 disabling conditions. And over 55% of the reported serious adverse events have been not mentioned, because in America, it is the duty of the doctor who is seeing the patient to report that event. And most of the doctors are not reporting because of the whatever, the pharma pressure, or they're afraid. However, the number of the HPV vaccine related injuries and deaths reported to varies is assumed to be underreported, as I told you just now. And as of December 1, 2024, 961 claims have been filed to the Federal Vaccine Injury Compensation Program, that is VICP, for 23 deaths and 1,938 injuries that occurred after HPV vaccination. And to date, US Court of Claims has compensated 189 children and adults who have filed claims for HPV vaccine injuries. So these are the data which I wanted to present, but now the time is less, so I will not be, but just to, I'll just show.
I had a few questions, Dr. Sujata.
Yeah.
When you're giving amazing information, I mean, this is a perspective that I think we all should as doctors see, because we do get blinded when we read papers, and we do have the way this is being presented. So my question to you is, one very important thing that you touched here was fertility, which I think you mentioned. You showed an article saying about fertility,
Yes.
how the vaccine is affecting fertility. Do we have enough papers on that?
There are papers, not enough, but at least 5 to 7 papers. PCOS, not PCOS, premature ovarian, the terms of premature ovarian failure is there.
Okay.
Already studies are being they are present.
Okay.
This particular paper which I mentioned, which has been retracted, is available for reading.
It is available. Okay. So
it has been retracted from the journal, but it is available for reading. You can read it. Yeah.
So, and another thing that when you said about vaccination causing deaths and stuff, would you say that any vaccine can do that, or it's just I mean, we definitely are looking at the HPV vaccine here, but when you say about deaths, I mean, the last article that you just quoted on December 1, it's very surprising to see that so many deaths are happening. And I mean, there are cases being filed in the court and stuff like that, but there's no solid data on it, is it?
There are already solid data
About the deaths?
About deaths. And few of the autopsies also. Dr. Amitabh Banerjee can throw the light, because we had one cardiologist during one of the sessions with the COVID vaccine, the deaths, parents who had assembled, parents whose children had died because of the COVID vaccine. they had assembled because they were fighting for there was a press release and they were fighting in the Supreme Court for the justice. So one of the famous interventional cardiologists of Delhi had said that autopsy is the final finding. So few of the autopsies in the HPV vaccinations reports are available where they have find out the LP HP1 particles along with the adjuvant. See, another important thing which I wanted to highlight that these all the trials, mostly 99% of the trials of the HPV has been not done properly in the terms that they have uh, in randomized control trials, we have got the controls. And in controls, the placebo is almost always innocuous. Innocuous means saline is to be used. In all the trials, they have used adjuvant, aluminium hydroxide or aluminium sulfate as an adjuvant. And there are now a lot of studies have already, more than 2,000 studies have clearly.
Isn't that, Dr. Sujata, isn't that true for most vaccines?
That I haven't seen
Use
properly.
adjuvant all the time, right?
But for this particularly, it has been highlighted very clearly that they have this placebo was aluminium hydroxide or aluminium sulfate, and in few of the cases, for I think in the Indian Cervical, they have tested against hepatitis B. How can how can you test a vaccine against another vaccine? That is not a randomized control trial. That is not a randomized.
My question is to Dr. Amitabh. Dr. Sonal, I will come to you because I have a long list of questions for you. But quickly, Dr. Amitabh, there is data in favor of vaccine. There is data against vaccine. At this point, when we are standing in 2024, going into 25, what is your one thing that you can say that should we go for vaccination of our kids or should we not?
There is incomplete data because there are so many uncertainties, and one child dying also is one too many from a vaccine. Particularly, you are giving vaccine to a healthy person, and you don't know whether that child would have contracted HPV, whether that child would have got cancer, and you are giving the vaccine. So as on today, there are so many gaps. So particularly, we have never gone for a like if the measles vaccine is there, it's a well-tested vaccine, and the measles deaths we know, and it prevents measles 100%. So we can take a chance. But here we don't know whether the HPV vaccine will prevent cervical cancer. That is actually a propaganda that it will prevent, and that we don't know. We can only know that it prevents HPV infection. We don't know whether, and it doesn't do away with cervical cancer. Screening will prevent deaths from cervical.
Yeah,
So
that is a
so
very good
when
point.
there are so many, why invest? I am talking of the health economics. Why invest in so much? And when you are having maternal mortality, which is 10 times higher than cancer, cervical cancer. If you are really worried about the population health, young mothers are dying. And cervical cancer is the older age group, and most of the mothers are not living so much to get cervical cancer. They are dying in childbirth. So our budget, we have to prioritize our budget.
Excellently put, Dr. Amitabh. Dr. Sujata, I'll come to you. And I know you don't have a presentation. So can I ask questions or you would like to say some things? Because a lot of has been discussed. And biggest, I think the takeaways till now are that, is it safe for us to vaccinate our girls? What is your point of view, Dr. Sonal? Dr. Sonal?
Yeah.
Okay. What is your point of view? If we, do we vaccinate or we don't? Like, let's start with that.
See, what I work with this is the protection from single dose vaccine of HPV against HPV. The guidelines just come from the International Agency for Research on Cancer, as per WHO. Now they're moving forward to a single dose vaccine, and we are talking about whether vaccine should be given or not.
Very true. And okay, so
And
what is your let's hear what you have to say about the, this is a prevention we can have of cervical cancer. So we should discuss that.
Villages to provide services to poor patients. And I do surgeries there. And we have seen that if I provide herd immunity to a population who is localized in a remote location, there is no harm in providing that. so that because the services for cancer treatment will never reach there for another 20 years, 25 years.
So you're
So
saying the single dose vaccine is coming now, not the 3?
the single dose vaccine can provide a herd immunity to these girls. I think, this will really be helpful. And we know that in Australia, they have, eradicated cervical cancer by giving this HPV vaccination. Then why not we take this example and we introduce this vaccine in our country so that our girls are protected from cervical cancer? And
What is
yes,
the age group, Dr. Sonal? What is the
we
age for
then
vaccine?
9 to 13 years, 9 to 14 years before their sexual encounter only. And yet the strategy which has been proposed, that the 90, 70 and 90 strategy given by the WHO, that 90% of the girls should be vaccinated, 70% of the sexually active women should be subjected to cervical cancer screening, and then 90% should receive cancer care. I think this strategy has to be followed. And of course, the important points that you should stop smoking and avoid multiple sexual partners and
Right.
genital hygiene and avoid long-term use of OCPs. I think these strategies must be told to the public at large and to prevent cervical cancer. But yes, as proposed by the WHO,
Yeah.
and after scientists are in active consultation and active participation in these studies, Dr. Partha Basu, Dr. Nirja Batla, I think they are big names and they won't advocate a vaccine unless and until they have good proof
No,
against.
that's see, we have to see as doctors, we have to see both perspectives. And if we don't see and brainstorm, then we can't be the better, propagators of these things. So my next question is like, people are getting, I've seen ladies in 30s, 35, 40, 45 getting the vaccine. What
No,
do you say to that?
the best person to be vaccinated is girls and boys between 9 to 14 years of age, so that we work towards developing herd immunity in our population.
So when Dr. Sujata said it's only 9 years, the the antibodies will be there only for 9 years, then what's your take on that?
See, we are developing herd immunity against HPV.
Got it.
We have to develop the herd immunity. We're not targeting a single person.
Okay, right. And what's your take on the fertility being affected after the vaccine?
I don't think the fertility can be affected in India.
Okay, that's another topic in itself.
But
And
fertility is already decreasing in India. That's why the IVF centers have
But
mushroomed like anything.
of polycystic ovarian
Already we are
disease is
facing
not.
yeah,
problems.
fertility generally, yes, of course, the general fertility has
If
decreased,
the
but
thing is, the girls are gaining weight and PCOD is another problem which is coming up at a very large scale. I think fertility reduction is to be attributed to that, not to cervical cancer vaccination.
okay, that's true because see, fertility is being affected, yes, in urban population, but here I think the what we saw in the data also that there's lower and middle class incidence of cancer, of cervical cancer and HPV is higher, than urban. So, and our population is increasing. So, fertility is definitely not going anywhere. I think we should not even. I think that
So,
should not be a part, right, Dr. Sonal? That's what we are saying. Yeah, so fertility should not be an important thing. My point is what Dr. Sujata had said about the deaths, following the vaccine. Now, is it that any vaccine can cause the death? Yes, of course.
see, I have been vaccinating girls since 2013,
Okay.
and this 2024 now. I haven't seen even a single death, and I haven't seen any gross morbidity in any patient.
What about boys? We are not vaccinating boys?
We are the guideline has come last year only that you start vaccinating the boys also. So let's see. I mean, the budget is. The awareness is for girls only. So let's start vaccinating our girls only.
Okay, so and if let's say a young adult, 22 years old,
Hmm.
never vaccinated with HPV vaccine, comes to us, not sexually active, should we vaccinate? What is
Yeah.
the deadline?
Guideline says that you should vaccinate boys less than 20 years of age.
But
But
if they are 22 and they're not sexually active, so I'm just trying to understand from point of view as a practitioner, like should we still vaccinate, or it's of no use?
They should be.
What is the age where it's of no use?
See, the age, it has been advocated that you can give it till the age of 45 also, but best age is less than 26.
So you can give it up to 45.
Yeah, less than 26, it works best. And
But
better, but best is less than 14 years.
yeah, that's fine. 9 to 14 is the best age. But there are people getting even they are sexually active with multiple partners and they are under 45. Should they be getting the vaccine?
See, till 26, they're saying that you should give them vaccine. And after 26, if you are giving, the efficacy won't be that good.
Got it. So now we heard two points of views here from Dr. Sujata and from Dr. Sonal, and Dr. Amitav has all the numbers with him. But still, I think if all of the panel agrees, we still have to do more. Still has to be more data for the side effect profile. I think that is what we are missing. Am I right, panelists? Yeah,
So
right.
it's a benefit also, because any highest body or any highest authority says something, he or she opinion doesn't count as evidence. The data should be in the public domain. And as you said, deaths and other things, it is the general yet to policymakers and the farmer to put it as coincidental. Like if there is one death in 800, that is the death from COVID vaccine which has come out. A clinician does not see 800 patients. He sees 799 patients, he will see no deaths, no side effects. But one death in 800 is one too many. In a country of 1 crore, 100 crore, if you give, there will be about 10 lakhs deaths. So it gets diluted at the population level. So the population level figures, monitoring and surveillance, and that's why adverse event reporting by an independent body is very important. It is just like going for super fast trains. We are going super fast trains and old tracks are there. You require new tracks. Derailments are there at the remote areas. Nobody is noticing the casualties. So unless you have a proper health infrastructure equitably distributed, you are not going to catch the adverse events. You are not going to catch. You are just going to push the super fast trains on old rickety tracks. So that is what we are going to do. That's why I said you can't push it in the national program where we don't have the public health infrastructure. Let anyone take it on her cost or his cost. Let it be in the market. Then we have a long-term safety here rather than going all out.
Okay, I think everybody's got the takeaways from this panel. I think it's a very, very good discussion that we had. And I think the takeaway is that we know the age of vaccine. We know that there are side effects. We know that the holistic treatment also should be involved. I forgot to mention ozone therapy in my talk, actually. Ozone therapy can be very beneficial adjuvant therapy when a patient has developed cervical cancer. So with this, I would like to conclude, and the team leaders can over there, Dr. Ruhi, you can ask the general Q&As.
Yes. So thank you so much. I think it was a very exciting conversation. So I'll take up a few questions. So I see a lot of concerns in the chat that, okay, now should we go ahead and vaccinate our girls or not? So I think Dr. Huda, you already asked that.
Yeah, I did. So I think we do have conflicting views on this, but I think on the whole, if we are creating herd immunity, my take would be to go ahead for the vaccine. That is my take, very personal, not to be. Yeah, for herd immunity, I like that particular thing that's really touched me. That herd immunity.
I have another comment from Dr. Vivek Kadambi here. In the attempt to improve herd immunity, we are in many cases increasing the number of carriers. That's even more dangerous.
Dr. Sonal, would you like?
No, not increasing the number of carriers. We are just instigating immunogenicity. Immunity will develop.
Okay.
And
that's for all vaccines, no?
Yeah, it happens with all the vaccines. Why are you taking flu vaccine now? Because you know that it provides protection over a time.
There is always going to be a world of vaccinators and non-vaccinators. There will always be that. And I think we can never come to the full and final decision, Dr. Ruhi. I think so. I think this is a question we should.
Vaccine also, but polio, now see, polio has almost gone away. So I think this vaccine will also do wonders. And if it has come to single dose, I think it should be given.
Dr. Mittal, Dr. Banerjee, do you want to add to this?
Polio had only a few strains. Here we have got 200 strains. So polio vaccine was efficacious. Here we don't know. We don't have, the trial has never been completed for the end stage. And herd immunity, I am first time hearing in HPV herd immunity. In COVID, we never accepted herd immunity, which is a homogeneously spread. Herd immunity affects in sexually transmitted diseases. These models do not work because there are some very high risk groups who indulge in very high risk behavior. It's a very heterogeneous. That's why I said if you want to try out the vaccine, first try it out in the high risk group among the commercial sex workers and the general population. The outcome will be so less, you will not get any definitive answers. And it will be just promotion. Film stars will promote, cricketers will promote, and pharma will promote. So evidence has to be collected where the outcome is more like high risk groups. So here the herd immunity doesn't follow the pattern as in other communicable diseases.
And one more thing,
Very good.
and one more thing I just want to say is already the studies are showing that after giving the vaccine, the replacement means other vaccines, other type of the HPV infection, high risk, they get replaced. For example, it's just simple to understand. Suppose we give the antibiotics for a prolonged time, fungus infection occurs in the body. So similarly here, if you, because vaccine is not containing all the high risk type, vaccine is against only 7. And now the studies are saying that 10 more high risks are going to be identified. Study by the HALEC has shown that 10 more are going to be identified. So it get replaced by the some other oncologic HPV types also. So I don't understand what is the herd immunity when the more than 200 types of the HPV infections are present.
Yeah, to that, Dr. Sonal, please add something. And I can't hear you.
See, diseases will keep on coming. You can't stop the diseases from coming. If one virus has, now we know that this virus is carcinogenic. We are working against it. Other viruses will definitely come. You can't stop the viruses from coming in. They will definitely come.
So we'll have to take a vaccine every day then. 100 viruses we have to take. I mean, we have to just make some priorities, no? Like if the 100 viruses come, we will take a vaccine every day. I mean, there has to be some, and there everybody will find a new virus every day.
So
we have to be.
Medicine,
I think we should go functional medicine way, prevent it, screen it, and just
Final common pathway is safe sex. Final common pathway is safe sex. And it has come down in last 3 decades. You see the number, it has come down. You know, you have a rotavirus vaccine, doesn't even still 2,000 children die daily from diarrhea. Rotavirus did not prevent diarrheal deaths. Similarly, we have a vaccine for hepatitis B. It doesn't prevent so much as we expected. It did not eliminate cancer, liver cancer. So it's a promise which is not worked. Polio is a communicable disease. This is we are trying to use the same year in a non-communicable disease which we don't know whether it will work or it will not work. There are so many factors for cervical cancers. How much is attributed to HPV, we don't know. As Dr. Mittal said, some percentage, 2%, 10% out of so many million. So still the bulk of cervical cancer, and many people will be lulled into complacency. They will not go for cervical cancer screening. As it is today, people are not going. So it will create so many wrong messages.
So the WHO is 90, 70, 90. I mean, they
WHO, I am not having any faith in WHO as on today.
You have to screen, you have to vaccinate.
You cannot, we are science. We are not, he is not the Pope. In religion, there is a Pope, there is a Sankaracharya. Here we are talking of science. In science, when it goes towards certainty, it is going towards faith. It is going away from science. Be it WHO, be it anyone.
Yeah, and if we are talking about hepatitis B, we all doctors are taking hepatitis B when we know that we cannot prevent it completely. But
I think it varies from vaccine to vaccine. That's what Dr.
I am not against HPV vaccine also. I am against it being used in the government program under the taxpayers' money. It is not a health economics when the outcomes are uncertain. So let people take it on their own choice. Let doctors take it. Let anyone take it.
Yeah.
So just to add Dr. Mittal said, I think there is enough data on how the immune system dysregulation can also happen post-vaccination. And we also, in functional medicine, where we handle a lot of autoimmune condition, we see, how many of these autoimmune conditions have been triggered post-vax.
They get triggered by vaccination. That is true, Dr. Ruhi. That is true.
So I think anyone who is keen to take, the cervical vaccine or be it any other vaccine, please
I
do.
think let's push for screening.
Yeah, please do a lot of reading yourself. Take an informed decision. I think we had amazing panelists to share their insights on this topic that is around the country. So yeah, take an informed decision. There is enough data out there on both aspects, and yes.
One thing I would like to add, 2 screens are important for every sexually active woman in her life, between 35 to 50 years, and preferably it should be HPV.
Okay,
Yes.
this is agreed to.
Yeah. Don't go for
Unanimous agreement. Yeah.
But still,
Screening.
see again, if we go to the, as you were saying, mid district and villages, this testing is not available. Even the cytologist
that
or
we
the
should
histologist.
concentrate
So
on
we
that
need to
first.
focus more on the pap smear or LBC at the village and the district level. It is a costly test.
3 things have to go hand in
We're
hand.
not here to discuss about Delhi alone or the metropolis. We are here to pan India. So at pan India, again, pap smear and LBC is the way forward, at least in the beginning. I have taught MSMD doctors to do the pap smear at district level. Alvar, MSMD, they don't know how to do the pap smear even. So I have taught them to do a pap smear. So again, we have to see a lot of things, the way the education level is going down, the way the money is being think as all and more pervasive thing. So HPV for the metropolis and the way facilities are available, yes, no doubt about that.
No, but screening for HPV, that is where the money should be. Right. Time is up. Time is up.
Rather, cervical cancer, screening for cervical cancer. Forget about HPV, screening for pap smear. Forget about HPV as well. Lot of
Should we not do?
uncertainties.
No, but pap smear we are doing, but also we should be doing HPV screening with it, no?
HPV screening has to be done, sir, so that high-risk group can be, diagnosed.
No, there are so many fallacies in that, but definitely because it is science is saying that cervical cancer cannot occur without HPV. We are doing it, but HPV test doesn't indicate active, persistent, or the transforming infection. It just indicates that the virus is present in the body.
I'm sorry to interrupt. We've already over time, so I'll have to ask you to pause here. But I'm sure if we can manage some time later or tomorrow, I think it's an amazing discussion to continue. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.
Thank you very much.